Next gynecologic mass we'll talk about is a hemorrhagic cyst, which is also a great mimicker. The typical appearance of a hemorrhagic cyst depends on how big the cyst is and how long it has been between the incident of hemorrhage and the time of imaging, and that's because the appearance of blood evolves with time. Common appearances include an ovarian cystic lesion filled with low-level echoes and lots of thin strands and/or septations. Oftentimes, the clot within the hemorrhagic ovarian cyst will be retracting from the cyst wall, and a hemorrhagic cyst should have increased through transmission. Here are some typical examples. Here is an example in which you have innumerable fine strands and septa within a hemorrhagic ovarian cyst. And here is an example of clot retracting from the cyst wall, giving you a concave margin with the fluid in the rest of the cyst. Another common pattern would to have a straight margin when this clot retracts from the cyst wall. One of the pitfalls is to mistake the blood clot within a hemorrhagic ovarian cyst for solid tissue. Here is an example of one that was initially mistaken for a neoplastic process because of this solid appearing tissue within the cyst. This was also seen at endovaginal ultrasound. This is an old case. In more recent years, this pattern of retracting clot has become more widely known, and this mistake wouldn't be made because this is really characteristic for retracting clot. Fortunately, this patient did not go to the OR. A follow-up ultrasound was performed, and here you can see the hemorrhagic ovarian cyst is entirely gone, and now there's a normal appearing right ovary with normal follicles 6 weeks later. So as a general rule, if one sees an adnexal mass in a woman of menstrual age, I recommend one asks oneself the question, is a hemorrhagic cyst a significant possibility? If a hemorrhagic ovarian cyst is a significant possibility based on the ultrasound appearance of the mass, and if the patient is stable, another step should be performed, and that is to perform Doppler to be sure there's no blood flow within the tissue within the cystic mass. And if there's also no blood flow, then a repeat ultrasound should be performed in approximately 6 weeks to assess if the hemorrhagic ovarian cyst resolves. Here is an example of this. Here is a cystic lesion in the left adnexa with a lot of echoes, a lot of strands. You can see that at color Doppler evaluation, there is flow at the periphery of the cyst, but not within the material within the cyst. And sure enough, as a result, we waited and rescanned the patient 6 weeks later, and you can see that the ovary looks normal in appearance 6 weeks later with normal appearing follicles. The cyst has resolved. One other potential problem, though, is to see flow that is at the periphery of the cyst and partial volume making it look like it's actually within the cyst. Hemorrhagic cysts and corpus luteums often have a rim of flow around the periphery. And here you can see this rim of flow at the periphery has been projected into the region of the structure, making it look like there's actually blood flow within it. However, here is the peripheral rim of blood flow, and it's not just at the periphery here. It is a spherical rim all the way around the lesion. And so as you come out of the lesion, you can show blood flow within it. And that is shown here, where on the cine clip you can see rim flow, and then you can see flow that could be projected into the cyst. So it's very important to have a good 3D feeling for where the flow is coming from. Another hemorrhagic cyst pitfall occurs when the cyst is imaged soon after the episode of bleeding, because in this stage, oftentimes the material within the hemorrhagic cyst is echogenic. The blood may be echogenic. And echogenic ovarian lesion can be mistaken for a dermoid, since dermoids often have that dermoid plug that is echogenic. The example on the left was done many years ago. It was thought that this echogenic lesion, which is coming from the ovary, you can see peripheral ovarian tissue here, was a dermoid. The patient had surgery, unfortunately, and the diagnosis turned out to be a hemorrhagic ovarian cyst. A more recent example of this is shown here, highly echogenic mass originating from within the ovary, which has follicles here. And this patient did not have surgery, but had 6-week follow-up ultrasound, and the cyst had resolved because it was a hemorrhagic ovarian cyst. Now, there is a clue on each of the images that one might not be dealing with the dermoid, and it's something to look for when an echogenic mass is seen, and that is the increased through transmission. You can see increased through transmission behind both of these masses. That would not be typical of a dermoid plug. A dermoid plug would attenuate the sound. Yes, it is true that the cystic component of a dermoid could have increased through transmission, but that through transmission shouldn't be right posterior to the echogenic mass. So if you have an echogenic mass, you're thinking dermoid, but you see increased through transmission, you should take a step back and ask yourself the question, could this be a hemorrhagic ovarian cyst? And if the answer is yes to that question, a 6-week follow-up ultrasound should be performed. Another gynecologic mass that can cause some confusion is to see a multicystic mass. Here is an example of a big multicystic mass with multiple septations within it. Usually these masses will be cystic ovarian neoplasms, and so as expected, this particular mass was a mucinous cyst adenocarcinoma. However, multicystic adnexal masses can be simulated by other pelvic pathology, in particular by dilated fallopian tubes that are tortuous, as well as by vascular structures. So here we have what looks to be a multicystic ovarian mass, seen both on transabdominal ultrasound on this image and at endovaginal ultrasound here. However, when one looks at this at real-time evaluation, you can see that the components of the mass are tubular and connect up, and this was not a multicystic ovarian mass, but rather was a dilated hydrosalpinx. Vascular etiologies can also simulate cystic masses in the pelvis. It looks like there's 2 large cystic structures within this pelvis, but color Doppler shows that these are simply large pelvic varices. This next case was another interesting example of the phenomenon of a vascular mass or a vascular structure simulating a multicystic ovarian mass. This lesion here was thought initially to be a lesion in the ovary, and you can see it's already being measured. However, when you look in different scan planes, in addition to the cystic component, you see this elongated, unusually appearing structure that looks almost like a fetal spine at grayscale ultrasound. But this patient's not pregnant, so this can't be the fetal spine. When one puts color on the cystic component, it fills completely with color Doppler, indicating it's vascular. And then when one scans the structure that looked like a linear fetal spine, you can see it's actually a vascular structure with blood flow within it. And then when you sample from the interface between the cystic area and this vascular structure, you can see that you get to and fro flow, just like you might see in the neck of a pseudoaneurysm elsewhere in the body, for example, in the groin status post-cardiac catheterization. And in fact, this is a pseudoaneurysm. The linear structure is a bypass graft, and this is a pseudoaneurysm originating from the bypass graft. Fortunately, color Doppler had been performed. More commonly, though, is to image some adnexal blood vessels that are slightly prominent in cross-section, making them look like follicles. And so for a while it was thought at grayscale that this might be the ovary, but it turns out that this was the ovary here, nicely shown by using color Doppler, where we see the blood vessels here, and we see the ovary here. So it's important to put color Doppler on any abnormal cystic structure that you don't expect to see anywhere in the body. The one time somebody forgets to do this is, by Murphy's Law, going to be the one time that it turns out to be a vascular structure.